So I am with Mr. Fernando Ruiz, who is the Deputy Minister of Health of Colombia. So, sir, I have a few questions concerning the health care reform that Colombia has gone through since 1993. Just briefly, what are the lessons that the Ministry of Health has learned with regards to this reform in terms of the planning process? Are there any challenges that the country went through in planning the reform, and are there any lessons that has been learned?
Okay, I think the very important lesson from Colombia, the first one is when you implement a reform, it's very important to have a baseline. Where, where are you before the reform or in the early stages of the reform? We never had a baseline in Colombia about people access, utilization rates, and health status of the population. So, to get good like the legitimacy, it's very important for the people to know that the reform is changing the way that the people access and the health results. So this is a very important issue. The second one is how to have long-term objectives with the reform. How can we change, and what happens if you are not able to change the, 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 the issues that you want to change? In Colombia, we had some problems because we set a goal to have universal health coverage by the year 2001. This was not accomplished because it was very hard to finance the about 20 million people who needs to be subsidized. So we accomplished that 10 years later, but it's necessary to explain to the people that how difficult it is to get some of these issues. The third one issue is how to deal with private and public stakeholders. This should be very well conceived because public stakeholders have their own interests, private stakeholders have other interests. In the Colombian system, we mix both. We mix public and private hospitals in the same system. We mix public and private insurance in the same system, and they compete with each other. For the last 20 years, we had a lot of conflicts between public and private. So you need like to make to have a route for how to deal with this public-private mix in the political sense and also in the planning sense.
Perfect. Thank you so much. So I guess the three key issues here are obviously the first one that you mentioned about understanding what is it before the reform, what is the health status before the reform, being clear about your objectives and the technicalities of achieving your objectives. And the last one is about trying to not to merge, but to have some sort of system where you can regulate the public and private interests. Okay, thank you so much. The second question regards the financing of the healthcare reform. Colombia now is a middle-income country, and we have some middle-income countries in Africa, although some are low-income. First of all, do you think that some countries in Africa that are low-income can finance such a health reform? And briefly, very briefly, what could these health financing mechanisms be?
most mechanisms should be private for the poorest country because if people don't have capacity to pay, it's very hard to make them pay. But how to make the richest people in every country compensate and develop some solidarity is very important also. Colombian health system in that was the design of the Colombian health system was very good in that sense because we made like the richest people who work in the formal sector and who earn more money to subsidize the poorest people. 1% of the actual contributions for health in Colombia for the richest go to a fund for the poorest people. This is a very interesting way to help to finance the poor people enrollment in the social insurance scheme. The other issue is the social structure in our country is changing a lot very quickly. And Colombia, as I said, we have about grown in middle class about 12% in the last 10 years. And I understand some African countries
Yes,
growing
effectively.
faster than that. So you are going to have in the next future a lot of people who can contribute. You have to develop the mechanism to make them contribute with solidarity to the poorest people, who are mainly people in the rural areas and people in the poor neighborhood in the large cities. So what Colombia made was a big fund, a financing fund that make this cross between the richest and the poorest and make an assignment, a capitation assignment for each one in the insurance system.
Perfect. Thank you. So, just as a summary, you're saying that there needs to be some risk pooling and solidarity, whereby the rich can help pay for the poor in a sense, and you've given specific figures to say 1% of the funds that are provided by the rich is used to subsidize the poor. So a lot can be done indeed. Thank you so much. The last question, I promise it's the last question, is about the financial sustainability of the healthcare reform in Colombia. You have talked about this health financing mechanisms, which has worked for Colombia in the past decade because, well, coverage has increased. Is it feasible in the next 10 years, in the next 20 years, this same financial mechanism?
I had two crises in the financing the Colombian health system. The first crisis was in the year 1997, 1998, and 2000, when Colombian economy were down and we have kind of a recession. This crisis was because people lost their employment, their salary were lower, and this subsidized mechanism didn't work so well because the income base was smaller. So they got underfinanced at this point. From this year to now, Colombian economy has been growing at 5% each year. So we have been able to maintain the enrollment. The problem that we are facing now is the technological pressure that is increasing costs and make drugs and medical treatment less costly. So the system, the services are costly than before, and and we need to develop right now a mechanism to contain the cost to make the system sustainable. This is what we're working right now.
Thank you so much, Mr. Fernando. I really appreciate, and I thank all the people in the community of practice that work in over 23 countries, most of them in Africa, would really also appreciate all the lessons we have learned from you today.
Thank you very much.
Thank you.
Bye.